Good evening, everyone. My name's Jason Roberts. I'm from the University of Queensland. Just want to check that you can hear me, those out in the webinar land. Maybe if I can get Ben Rogers to give me a thumbs up because I can see his face. Thanks, Ben. It's a pleasure to be hosting this still tonight. It's been quite difficult for many of us to go about our usual business with the challenges that COVID-19 is providing to us, but I think it's really exciting that we can still provide this webinar to all of you throughout Australia, because I think that this area of OPAT, or outpatient parenteral antimicrobial therapy, is something which is of great interest to the healthcare system, can provide many benefits, and is an area whereby lots of people want to know more about what others in Australia are doing and what some potential applications are, of course. You'll note on this title slide here that we're acknowledging the sponsors who make this possible: Pfizer, MSD and Baxter. We're very grateful to the support that they are providing us, because essentially it allows us to make these webinars something which is as accessible as can be to as many people as possible. My final point would be is that these webinars are being recorded and they will be made available later on our YouTube channel for CRE REDUCE. That's the NHMRC funded Centre of Research Excellence, for which I'm fortunate enough to be director, and the manager of which is Nerman Karamujic, who has been in contact with many of you and provided you with details about how to dial in. So more information about how to access those videos for yourselves or others at a later date will be sent out, such that you can access this information as you need. So without any more talking from me, I'm going to introduce Ben Rogers. Ben Rogers is an infectious diseases physician from Monash Health, and he's going to lead us off to describe why this is an important area and to talk about pulmonary infections in the outpatient setting, and then introduce how each of the speakers are going to work towards describing this topic. So I'll hand over to Ben. Thanks, Ben.
Look, thank you so much, Jason. And it is amazing that this has managed to get off the ground despite everything going on at the moment. I'm going to flick to my presentation now. I've really just got a few introductory remarks. I guess last time I shared a conference with Jason, he complained about the quality of my jokes, so I'm limiting them and just going to move on quickly till we get to the main speakers. Can everybody hear me? Yeah, I'll assume that's a yes. So I'm just going to share my screen with you.
Oh no, what? Pardon? No, it's more comfortable over here too.
I think
the laptop and everything.
Okay. If everybody could mute, that would be great. We're getting a lot of background noise, and I'm just going to share my screen now. All right, and we're good to go. We've come up at the wrong bit. There we go. So look, this whole session is really about pulmonary infections in the outpatient setting. As you've heard, I'm an infectious disease doctor. I run Australia's largest hospital-based hospital in the home program. We have about 200 beds over 3 different sites, and I guess it's a real passion of mine, hospital in the home. So I'm excited that we're all coming together to talk about this. I've got a few disclosures to make there. So I guess the first thing I want to just do quickly is talk about what Jason mentioned briefly, which is that, you know, this session is called OPAT, or outpatient parenteral antimicrobial therapy, which is, you know, in strict definition about the delivery of antimicrobials to outpatients or in the community. Whereas in Australia, we often tend to have what we'd call hospital in the home programs, which are a broader program of, you know, hospital care outside the hospital walls, and tend to focus on a more medical model of care than an OPAT program, which might just be about the antimicrobial delivery. The program I run really looks externally like a general medical unit with consultants, registrars and residents, and our patients have access to allied health if they need it, and all the other supports they might get in hospital. The real difference is they're sleeping in their own bed and with their own family. And look, I guess not all of you can run programs like that, but it really is something to strive for in terms of how we look after our patients, and we really service them in the community outside of hospital. I will flag this kind of emerging term of COPAT, complicated outpatient antimicrobial therapy, which is kind of a route-independent term. So this is really because, as a lot of you will know, we're increasingly have very effective and good oral antimicrobials. Although with some of the patients that could go on orals, there are other reasons that we don't want to just send them out into the blue ether. We want to be able to keep an eye on them. We want to be able to care for them, monitor their blood tests, side effects, psychological status. So this is really kind of a hybrid of an OPAT and a hospital in the home program, which is what's being used quite a lot in the United Kingdom at the moment. The one thing I will acknowledge before we move on, and for those of you that are involved in hospital in the home in Australia, I'm just really saying this so you can put it out of your mind, is that every state and jurisdiction in Australia is incredibly different in how hospital in the home or OPAT is structured and funded. You know, it emerged really in the 1990s, first of all in Victoria, driven by a public health funding crisis looking for lower cost ways to do things. But really each state has grown quite organically. And, you know, my service sits within a hospital. A number of other states run services independent of hospitals. Depending on where you are, your patient might be an admitted patient of the hospital during OPAT or HITH, or they might be an outpatient. And that's got completely different implications for access to PBS medications, MBS funded investigations and reviews. The eligibility rules vary completely between programs, and the way we access funding for devices also varies. So I guess the talks today are really focusing on the clinical side of things and acknowledging that there are different challenges for each of us in how we navigate these differences in our programs. The private sector is an even greater challenge, and for those of you who work in private sector, hospital in the home or OPAT, that is certainly an evolving area, and I guess it's something that we hope that the private insurers will increasingly get on board with, because it's a shame if private patients are denied the same care that they could get in a public system. So it's great, you know, this seminar series is fantastic, and I'm not sure if it's coincidence, but it starts with pulmonary infections, and pulmonary infections are really where OPAT began. If you look back at the literature, it was really in the mid-1970s in North America. Some of the first reports are actually pediatric reports in cystic fibrosis patients about providing their antimicrobials at home. It was driven then for cystic fibrosis and other things and chronic disease, but also again as a cost-saving measure at this stage primarily for the patients who weren't insured and couldn't afford in-hospital care. But you know, OPAT has really continued, and it's very heavily used for a number of reasons, which are kind of pretty obvious when you think about it. You know, for the health service, it's all about lower. It's about lower cost, lower length of stay, lower complications. For the patient, it's all about higher, you know, more time in the home environment, a quicker return to work. Some people don't even, you know, pause from their regular occupation when they come onto our programs, and avoidance of complications. And I must say, in our monthly quality and safety meeting, we always pat ourselves on the back that we have the highest patient satisfaction of any unit in the hospital. But then I kind of think to myself, if we don't have the highest patient satisfaction when patients are actually in their home, we're really going to have to ask some hard questions about ourselves. So it really is something that is a win for patients and a win for hospitals. And there should be no reason that we can't access this for our patients and use it readily. The four speakers tonight are really going to talk about some of the emerging areas and challenges in OPAT. And I guess we're going to hear Claire Wainwright talk about multi-resistant infections and cystic fibrosis, and, you know, some of the challenges we do come across with this, which hopefully Claire will cover, will include, you know, some of the newer agents and you know, how we use them and understanding if we can use them, and also increasingly complicated regimens that we use to treat multi-resistant infections, bacterial or mycobacterial, and working out how to actually deliver them to patients in the community. I'm really pleased that Geoff is going to talk about bronchiectasis and potentially some non-cystic fibrosis bronchiectasis, because for us, this is an emerging cohort. It's a cohort with less supporting data than cystic fibrosis, and it's a real challenge for us to make sure we're providing the best care to these patients and understanding which bits of the data on other patients we can generalise to this cohort and which bits we need to go out and find for them individually. Andrew's going to talk to us about the business of, you know, antimicrobial pharmacology. And as I've learned since I've got more involved in HITH, really there's a whole heap of different facets to this. As well as the pharmacology, we also have to think about the chemistry of the agents we use and, you know, their stability and how we manage their stability in our delivery systems, of engineering about how we actually deliver the antimicrobial, how we keep it at the right temperature, and tons of logistics. So really, the delivery of antimicrobials in OPAT is really far more of a challenge than it is in an inpatient setting, and something that requires, you know, a wide variety of knowledge to tackle. Amy's going to tell us about the patient experience, which is great because we can't forget at the end of all of this that really, you know, this is about, you know, keeping patient focused and inclusive, and we keep pushing the boundaries to include more patients with different conditions and in different living conditions and in different environments. And it really is a challenge for us to keep looking at this and keep making sure that we're pushing the boundaries on this. All right, so I'm just going to put one slide in on the elephant in the teleconference, if we can call it that. I think this is the reason we're not all sitting in Brisbane drinking fine champagne and eating caviar, which is I understand what the menu was. And really, I just wanted to say that, you know, COVID-19 is here and coming, and hospital in the home programs will be involved. It is a respiratory illness. Pediatric hospital in the home programs have a long history of treating acute respiratory tract infection. Adult programs typically don't have a history of treating acute infection other than in residential aged care facilities. But we will be there in a number of capacities. Oh. Sorry about that. So look, I would say that hospital in the home and OPAT programs will have an absolutely definite role in maintaining capacity for their health services. This will be caring for non-COVID patients, offloading the wards, offloading the emergency departments with patients that could potentially be looked after at home. We might be pushing the boundaries of who we take home. We might have to change the way we care for them, but this is going to be a really crucial role for us in what's expected to be the coming pandemic. We may also have a potential role in COVID patients, you know, and it's really a bit speculative what this role may be, but certainly it's been better to find in pediatrics, and we may be involved in clinical monitoring for patients who are marginal admissions that might be able to manage at home, you know, and are not at the peak of their illness, or potentially on patients that are only marginal for discharge that we can support for a number of days until we're more comfortable with them in the community on their own. Certainly supportive care is already delivered to pediatric patients, oxygen therapy and hydration. Whether that's useful for adults, it remains to be seen, and potentially management of secondary bacterial infections. Although again, it remains to be seen how that would be delivered and the role that would play. I will point you all to a HITH Society position paper, which is hopefully coming out in the next few days, really talking about what will be the massive organisational and logistic challenges of COVID on OPAT programs. It's been driven by James Pollard and Penny Bryant in Melbourne, but there's a number of us who've been involved. And parallel to that paper, there's been an enormous amount of sharing of ideas and protocols for COVID and hospital in the home programs. So if you are in charge of a program or involved, get in touch, and there's certainly a lot of stuff flying around on the internet. All right, look, that's all I've got to say. Thank you so much for listening to me. Now, I think Claire is our next speaker, Professor Claire Wainwright, and she's going to talk to you really on multi-drug resistant infections and the cystic fibrosis cohort.
Okay, I've no idea how to do this.
I'm going to unshare my screen.
Help. Will I come and find my tool? Sorry? Here? Okay, and I will get... So... All right. Am I live? Do I want to? Can I talk? Oh, well, hello, and thanks very much for asking me to talk this evening. I have to admit to a bit of a that I'm a bit of a fraud for this one, because I haven't really got to talk about hospital and the home. So I was asked to talk about multi-resistant infections and CF. So this is about that, but not so much about the hospital and the home. So hope you didn't think I was going to be talking about doing that very much. So there are a range of challenges. This is a picture that I like because it's from the Grampians, and I really like hiking. And this is a bit of a challenge walk, this one, but it's a very beautiful one. So if you want to go hiking, this is a great one to do. I do have some disclosures, but none really relevant to this, although they are relevant to cystic fibrosis. Now, things have changed in cystic fibrosis quite dramatically. And David Reed, who some of you will know from the Prince Charles, said earlier in sort of 2019, we may be the last cohort of doctors to see classic cystic fibrosis. And on the left, you see the classic cystic fibrosis, the infant who's very thin and who looks like they're not doing very well. And then if you walk into our clinic now in the 2000s, what you see are children who you wouldn't really recognize as having an illness. And that's a fantastic change. CF is a complex multi-system disorder, and I've highlighted in red some of the things that I want you to bear in mind, because these are things that really impact dramatically on multi-resistant infection. So these are patients with nutritional issues. These are patients who have upper airway problems that can lead to chronic infection in the upper airways. So that can be a reservoir for infection. And these are patients who have lung infections or airway infections with a significant amount of inflammation. And bronchiectasis is a problem because it causes areas to have disturbed ability to clear secretions. So again, that can be a major problem. The worldwide burden of CF is tricky to really understand because there are many places that don't really look for CF very well. There is even some CF in the Far East, so there is CF in China and Japan. It's far less common, but it is there, and there are now CF clinics actually in Japan. This is a condition that still has high morbidity and it still has a high mortality. It's an autosomal recessive condition, which I'm sure you're all aware of. The CFTR gene is located on chromosome 7 and it encodes for the CFTR protein. Now, this is a protein kinase activated ATP gated anion channel, and what that means is that it regulates the transport of electrolytes, in particular chloride and bicarbonate, across epithelial surfaces, with really quite significant consequences for the movement of water. And that's a particular problem in the gut and also a particular problem in the airways. Now, what's happened over time, you can see that adults with CF are now employed, having relationships and completing education. So things have really dramatically improved. And when you look at outcomes again, you can see on the left of each of these lungs that is the sort of 1996, and on the right the 2016 median FEV1 percentage predicted for each of the age groups. And then life expectancy at birth has also dramatically changed. Now, many of you will be not far off the 43, I imagine. I'm not sure in this room, but I'm certainly a lot older than that. But 43 to me seems rather young to be dying. So although we've done very well, we clearly haven't done well enough. So we've got a long way to go. So what are all these improvements in outcomes due to? Well, they're actually, we think, due to specialist multidisciplinary care. They're due to newborn screening, so if you pick up early, you can hopefully prevent infection in particular. They're really due to improved nutritional status, and that's key, and also really dramatically related to Pseudomonas eradication. And so that's where we come to the management of early infection and the management of chronic infection. And all of that has now led to the increased risks of multi-resistant infections in the long run. The prevention of pulmonary exacerbations is also a really important factor in reducing the loss of lung function and maintaining lung function over time. And then there are also new therapies that have started to be used that are improving the function of abnormal CFTR and leading to some hugely important improvements in outcomes. So I'm going to try and show you what the lungs in very young children can look like. So this is a 4-month-old who was routinely having a bronchoscopy as part of a clinical trial and was currently well at the time. And what you can see there is thick secretions. And what I want you to bear in mind is that the physiotherapist who assessed this child prior to the bronchoscopy said the child had no cough, was completely dry, there was nothing to find, but that's what we're finding. So these children can have significant problem, and this child actually had mucoid pseudomonas on culture. So the problem we have is also accessing and knowing what's going on. Whoopsie. So there is an increasing prevalence of structural abnormalities in young children with CF. And what you can see here is that gas trapping starts very early, but bronchiectasis increases over time. And by the age of 5, around half of the population of patients with significant cystic fibrosis will have bronchiectasis. And more than half generally have air trapping at birth, but again, around 50% by the age of 5. So let's come on to airway infection, and many of you will recognize some of these. The lung on the right is an end-stage lung that obviously that was taken out, but you can see these rather nasty infections that unfortunately we see quite commonly in people with CF, or relatively commonly. So over time, you see there's a changing pattern of microorganisms, and this is a pattern that's seen in all countries, really. And what we're seeing over time is that Pseudomonas aeruginosa becomes a more commonly isolated pathogen from the airways of people with cystic fibrosis. And rather worryingly, the sort of rather dark blue line that you can see is the multidrug resistant Pseudomonas. But we're also seeing quite an increase in MRSA, and this is the US population of patients with CF, but up to 30% of their population now have MRSA, which is a worry. So Pseudomonas has been the enemy for many long years, and it really is an organism that causes trouble in CF and is associated with significant inflammation and chronic infection. And it's associated with both increased morbidity, but also mortality. And many studies have looked at this chronic infection being associated, particularly when it's acquired early on. So if you are female in particular and you acquire Pseudomonas chronically under the age of 5 or 6, your mortality goes up dramatically. Now, what do we not currently do? Well, we look for Pseudomonas aggressively now. So we try and get at least 4 airway samples a year as a minimum, and we try and get them with any respiratory exacerbation in young children, because if we can pick up Pseudomonas, we can usually eradicate it when it's first there. And it's usually a community acquired, or not community acquired, it's an environmentally acquired organism in the first place, which is usually fairly sensitive. So first acquisition, we can usually eradicate just with inhaled antibiotics. So that's an outpatient treatment. However, these organisms can come back, and again, we can sometimes eradicate again, and we can keep eradicating, and sometimes we keep being successful with sometimes several years in between each eradication. But at some point or another, chronic infection can occur. Now, I'm not going to go through these, but there are lots of studies showing that eradication is effective. And the optimal therapy is still not known, but we do know it works and it reduces chronic infection. There are significant health economic benefits, and the minimal therapy should be at least 1 month of inhaled tobramycin. But if you don't test, you won't find. So we really have to deal with this. Chronic infection occurs, however, and then what do we do? Well, again, lots of different studies using different approaches, but if we look at the Cochrane review back in 2018, once chronic infection is established, the use of long-term inhaled antibiotic therapy is recommended as it's associated with improved lung function and a reduction in chest exacerbations. The best evidence is for inhaled tobramycin, and it's usually given month on, month off, and that's because of the studies that have been done. But we actually, again, don't really know the optimal therapy. Or what about staph? There's a growing amount of MRSA, as I said, and it's associated with worse survival. And there are now antibiotic trials and trials in MRSA. And for prophylaxis of staph, we still actually don't know. There are some studies. The Cochrane review suggests that prophylaxis will reduce Staph aureus, but the clinical benefits are uncertain and there are risks. So there's some suggestion that prophylaxis leads to an increased risk of Pseudomonas. So that's a bit of an issue, and randomized trials are currently underway. So what about MRSA? Well, we've got some evidence that it helps, but we don't yet know the appropriate treatment. And then there are a bunch of other superbugs, and I've listed them all here, but the biggest bugbear at the moment that's causing us trouble is non-tuberculous Mycobacteria, because there's an increased amount of it around, and in particular Mycobacterium abscessus. So there's a growing prevalence of NTM worldwide. The rapid growers have shown that there's a potential for cross-infection, and we can see devastating rapid deterioration, but we can also see patients who have these organisms that are not obviously having disease with it. And the treatment is currently based on guidelines that are really not evidence-based. They're complex, they're expensive, they're horrible, and they're prolonged. And it needs quite a lot of careful thought to know what you're doing with all of those. What about fungi? Mostly people are concentrating on bacteria in CF, but fungi are also a problem. And you can see a patient there with quite nasty ABPA. This was a patient of mine, actually, who presented out of the blue with really very severe allergic bronchopulmonary aspergillosis, and presented like that at diagnosis as a patient with what we would call mild cystic fibrosis, so a borderline sweat test. And that was the X-ray at presentation. So this is a clinical syndrome, and it can be quite nasty. Now, just out of interest, I thought I'd throw this in there because we've just been analysing our data on BALs in children with CF who took part in a longitudinal study. And this is a cross-section of the BALs at the age of 5 in children with CF who had a BAL, they had a CT scan and a whole range of other clinical outcomes. And what we found was that, in fact, these children, it was the total bacterial load that we found measured by qPCR that was actually the most relevant marker of disease, which is actually quite interesting because it wasn't specific to any one pathogen. So it was the total bacterial load that was associated with structural change and with inflammation in these children. So what I think that tells us is that overall the burden of bugs in the airways is a problem, and we need to be thinking about that when we're giving antimicrobial therapy. I'm going to race through shared strains of bacteria because that does increase the risks for patients, but there's quite a lot of evidence in the literature that we can share, that some of these organisms can be shared between patients in infective cough aerosols, and Mycobacterium abscessus is one of those organisms. And there was a paper back in 2016 that looked at some of the epidemiological possibility of patient-to-patient transmission, with some suggestion that that had occurred. And we also now know that cough aerosols produce small particles. In a cough aerosol, around 70% of the cough has small particles. And when we look at this in a more scientific way, when we look at those cough aerosols, we can actually see how far we can detect them with viable organisms. And this was a study in patients with Pseudomonas. And so these were 18 subjects with Pseudomonas, and you can see that you're still getting quite large amounts of Pseudomonas, up to 4 meters in some of these patients, but there's a huge variability in terms of the amount of bug that you get. And we can look at duration as well. And again, you see large amounts of organism can be still viable at 45 minutes. So that tells you that the likelihood is that you've got some airborne bacterial infection. And again, MABS detected in cough aerosols. And I've just thrown this in just to remind everybody that patients also have CF-related diabetes, and that can increase risks for infection. So let's get on to pulmonary exacerbations, and these are associated with loss of lung function. And 25% of pulmonary exacerbations have a permanent loss of lung function. And the definition of a return to baseline is a bit challenging across the age range. And exacerbations obviously vary in severity, but even mild exacerbations may be associated with permanent changes in lung function. And if you've got chronic Pseudomonas infection, that's associated with a much higher exacerbation rate. The same is true for chronic bacterial infections like Serratia or abscessus. And we use all sorts of treatments to try and improve airway clearance and to try and reduce exacerbations, including azithromycin in patients with chronic Pseudomonas infection and inhaled antibiotics in patients with chronic infection. CFTR modulator therapy also seems to work for this. So very important. Treatment of these exacerbations requires antibiotic therapy because you do see increase in bacteria. You often don't see a new bacteria except in young children, actually. So if you look in adults who are chronically infected, it's often the same usual bug, but perhaps some changes in the overall amount of mucus. And we don't really know quite what's happening in terms of the mix of organisms in the airway, sometimes in these exacerbations. But what we do know is that you need a whole range of multidisciplinary input to improve the outcome of these exacerbations. So it's not just antibiotics. You also have to have good, if you're going to do hospital in the home, you have to have really good airway clearance and good nutritional support. And one of the things that has always really worried me is that people call these things tune-ups. I've banned the term from being used in our hospital because they are actually potentially emergencies. Because if you lose lung function permanently, that means that's that. And we can't afford to do that. So I really object to the term, just for everybody out there in the ether. These are not just standard, oh, well, we're going to give IV antibiotics. Every single exacerbation carries a risk for these patients. Now, IV requires intravenous access, and care has to be taken to minimize trauma to the veins and avoid procedural anxiety in young children, because these are children who are going to require often not just one lot of antibiotics, they're going to require multiple courses. And so a great deal of care needs to be taken how we look after those veins. So if a patient's going on hospital and home, again, we need to be very careful that we choose the right mode of managing the intravenous access and the use of these antibiotics. And what about duration of IV antibiotics? Well, there's actually no adequate evidence currently at all, and it's highly variable. So shorter duration may be associated with better quality of life and lower cost, but it may also be associated with failure to resolve and return to baseline and lead to an increased risk of the next exacerbation and the loss of lung function. So that's a bit tricky. What about which drugs to use? Well, we usually use 2 IV drugs to cover a broad spectrum, commonly an aminoglycoside and a beta-lactam antibiotic, and that's based on very old data showing an increased time to the next exacerbation in chronic Pseudomonas infection if you only use 1. Now, what about antimicrobial resistance? Does that predict your response to treatment? Well, it doesn't. So if you just pick 2 standard antibiotics, but you've got organisms in your laboratory that are resistant to those antibiotics, you may still get exactly the same benefit as you would if they were sensitive. And that's the tricky thing. It's difficult. There also can be drug-drug interactions, which are now complicating life, and they may be associated with better or worse outcomes. And there's now some suggestion that if you use oral azithromycin to help with chronic infection and also reduce exacerbations, and you use it really more as an anti-inflammatory than as an antimicrobial, it works very nicely with some antibiotics, but it seems to have an interaction with tobramycin, and that may be both inhaled but also IV, and there's now some evidence that it reduces the antimicrobial effects of tobramycin, and so that you get less good response in exacerbations when you're using tobramycin with azithromycin. How we manage that when patients are on chronic azithromycin is as yet unknown, but it has produced some challenging concerns, and we do need to think about that. Quickly on to Mycobacterium abscessus. Am I going too long? Are we okay? Okay, tell me to shush and I can stop. Okay, so abscessus, rapidly growing, big problem. I've already said that. Treatment is long, toxic, 50% successful, roughly. However, Cochrane review, no drug regimens of proven or predictable efficacy. So guidelines are based on expert opinion, and treatment is pretty awful, 4 to 12 weeks of IV antibiotics, and consolidation of anywhere up to 18 months or longer with inhaled and oral treatments. The pharmacokinetics are mostly unknown in CF, but we're now starting to get a better feel for some of these drugs, thanks to some of the people here. Toxicity is a major problem that I'm sure you're all aware of, and we need to be really thoughtful about that. So the answer to no data is to be running a trial, and so we've set up a complicated trial. I'm not going to run through this in detail, but you can see it looks horribly complicated, but we're hoping to be able to get a feel for best approaches to treatment, it's a standing platform trial that's designed to determine the probability of microbiological clearance with acceptable toxicity for treatment combinations tested, inclusive of both an intensive IV phase and the prolonged consolidation phase with patients who have the disease phase, the pulmonary disease with Mycobacterium abscessus. And it is a complex study, but we're hoping it will help us to guide therapy down the track. These are the types of trial therapies we're using. In pediatric patients, we can't do the intensive phase in outpatients, but I've discovered that the adult world can and very successfully can give these drugs at home. So that's fantastic. It's an amazing team, which includes some of the people in this room. So my huge thanks to them. And then we've got new drugs coming through as well, which we need to start thinking about, both for Mycobacterium abscessus as well as perhaps for some other organisms. But these new drugs are starting to emerge, but we have as yet no real clinical data on them. And CF therapies are complex. Adherence is around about 50% for most treatments, but rather low for antibiotic therapy. And so let's just summarize all these problems. We've got abnormal mucus, problems with innate immune defense, you get early infection, airway infection which starts early, becomes chronic, and it's more antibiotic resistant with age. There's persistent inflammation and airway damage. We've got a very high exposure to antibiotics across the lifespan, which is getting longer, and other risk factors like nutritional issues and diabetes. Adherence, like all chronic disease, is variable, so antibiotic exposure is difficult, and infective cough aerosols have a potential for cross-infection. So that leads to a perfect storm for superbugs, basically. So some of the things we can do, well, we can be aware of long-term complications. We need to protect lung disease early. We need to have really scrupulous infection control. We need to avoid chronic infection, and eradication is better. We need to prevent and treat pulmonary exacerbations, and that means good use of IV and oral and inhaled antibiotics. And we need to learn to understand how to tackle multi-resistant organisms better. And to do that, we need clinical trials. So my thanks. Not sure how to. Get rid of that. Can't get out of this now. Help. Escape. Just get done.
Fantastic. Great. Thank you very much, Claire. For those of you that were just wondering if there's going to be an opportunity for questions and discussion, there will be at the end of Amy's presentation. So write them down. I'll get you to use the chat function within the video conferencing program, and then we can read from there and then talk about those issues that you raise. Okay, so next we have Dr. Geoffrey Eather, who is going to be talking on this one, second one. So Geoff's a respiratory and sleep physician from the Princess Alexandra Hospital, and he's going to be talking to us more on this topic. Thank you.
Thanks very much, Jason. Thank you for inviting me to speak. I'm really pleased to be involved with this session. So my brief is really to talk about pulmonary infection and how that might apply to hospital in the home, but particularly outpatient parenteral antimicrobial therapy. My talk is going to be a little less evidence-based for the simple reason that there's not a lot of evidence supporting the management practices, particularly for bronchiectasis, for adult bronchiectasis or non-CF bronchiectasis, but we'll talk about that as we go. One of the things I was also asked to cover was the role of HITH in COPD, and I'll talk a little bit about that as we go as well. So this is an overview of what I'm going to talk about, and half of the talk will be discussing bronchiectasis and some of the management strategies with antimicrobial therapies, some of the evidence base or lack thereof. And then the second half will be talking about IV antibiotic therapy in the outpatient setting, but particularly how we do it in the Metro South Health Service that I work in Brisbane. And hopefully that will then serve as a nice segue to the next talk, which Andrew will give, where he'll talk a little bit more about the details of some of the drugs that we give and how those how they're delivered. So the first part of the talk is really just a brief mention of chronic obstructive pulmonary disease, COPD. We all know what that is. It's a persistent and progressive airflow limitation or condition that's marked by progressive airflow limitation, most often due to cigarette smoke, but around the world there are other noxious dusts and gases that can be associated with this, particularly biomass, fuel exposure in the non-developed world. But it's a very common cause of emergency hospital admissions across the country. There are effective strategies, predominantly around smoking cessation and pulmonary rehabilitation strategies. It's a fixed airways disease condition, so a lot of the treatment strategies that we have don't work terribly well, and really hospital avoidance strategies are the main focus that we have for managing COPD in the community. There's a limited role for outpatient parenteral antibiotic therapy, at least in our jurisdiction. That's something we possibly should review, but we do have a limited role in looking at hospital in the home to treat acute infections in this setting. But most of those are managed in a brief inpatient setting. We know that antimicrobials, often we can get away with single agent, often oral antibiotic therapy. So it has less of a role, apart from those who develop pneumonia and have more chronic long-term complications. I'll talk a little bit more about that at the end. Bronchiectasis is a different matter. It's a syndrome of chronic cough, daily viscid sputum production associated with airway dilatation and bronchial wall thickening. And this is the condition that Claire spent a lot of time talking about in the context of CF. But effectively, on the right side of this slide, you can see a cycle of destruction that leads to the condition. So airway inflammation with airway structural damage, failure of mucociliary clearance, and that's one of the big issues in cystic fibrosis particularly, and bacterial infection drives a lot of the ongoing neutrophil recruitment, is a driver of disease progression. So the point is that there's a number of conditions that can lead to this in non-CF bronchiectasis. Obviously CF is a really important cause, but in our practice there's a multitude of other potential causes. And you can see some of those listed in that diagram on the right-hand side. Allergic bronchopulmonary aspergillosis, we see that as a condition that complicates asthma particularly, and obviously patients with CF can also get ABPA. We see bronchiectasis in patients with connective tissue disease, inflammatory bowel disease, infection associated with immune deficiency particularly, non-tuberculous mycobacteria, which is often a bit of a chicken and egg problem because NTM infection can cause bronchiectasis, but bronchiectasis really is a substrate that's ripe for NTM infection, which NTM or non-tuberculous mycobacterial infection likes to infect structurally damaged adult lungs. But infection is a dominant stimulus for ongoing inflammation and a driver of disease progression. So antimicrobial therapies in non-CF bronchiectasis, well, on this slide I've just listed the three categories, which is similar to what Claire was talking about in the context of CF. There's the first issue is the eradication of important pathogens. There's some good evidence that that's a good thing to do in CF. There's less good evidence that's a good thing to do in non-CF bronchiectasis, but I'll talk a little bit about that. Acute infectious exacerbations is the main situation where we use parenteral antibiotics and where I think the hospital in the home setting is often a good way to manage this. Long-term antimicrobial therapies, anti-infective therapies, immune modulation with macrolide therapies and so on, that's another area that's important, but I'm not going to talk about that. Of course, antimicrobial therapy is only part of the management. As Claire alluded to, it's just as important to have ongoing good sputum clearance techniques, physiotherapy, and other strategies, pulmonary rehabilitation, and good patient care in the community. And anti-infectives or antimicrobials are part of that. So common pathogens in non-CF bronchiectasis, similar to those found in CF, Haemophilus is a common or the most common that's been found in previous published series. Pseudomonas is also common, but probably the most important, just as it is in the CF population. There's a series of other less common, but some of them important, other bacterial pathogens, Staph aureus in particular, and including multi-resistant Staph aureus. And non-tuberculous mycobacterial pathogens are really important, and we'll talk a little bit about that when we talk about treatment strategies. So just as in CF, Pseudomonas colonisation or Pseudomonas isolation, or particularly if it's persistent isolation, is a harbinger of poor prognostic factors in non-CF bronchiectasis. So there's good data linking isolation of Pseudomonas with poorer mortality rates, increased rate of hospital admissions, exacerbations, reduced quality of life, increased severity of disease, reduced lung function, not surprisingly. And that graph on the right really just illustrates that in graphic form. The top blue line really is the course or survival time over 5 years or the percentage of survival in those who don't have Pseudomonas with no exacerbations compared to the green line, which is the other extreme, those with Pseudomonas and have at least 2 exacerbations per year. There's quite a significant change in survival time. Other pathogens also have an increase markers of inflammation, bacterial and inflammatory markers, but don't quite have the poor prognostic significance of Pseudomonas. Although non-tuberculous mycobacteria are really important pathogens, particularly Mycobacterium abscessus that Claire was talking about, which is also a bad organism to have in adult lung disease. Dealing with eradication therapy, there's really a paucity of evidence that this is a good thing to do in non-CF bronchiectasis. There's one randomised study, there's a number of other non-randomised studies. These are all small in numbers, a lot of observational data, and really the evidence would suggest that it is a good thing to do in terms of reducing the likelihood of isolating Pseudomonas with time. At the 12-month mark, for example, there's reasonable data that good eradication therapy will reduce the isolation of Pseudomonas at 12 months, although there's a high rate of recurrence at 12-month mark. There's some data that we reduced recurrence rates, exacerbation rates, hospitalisation rates, but we don't really have any long-term data to show this is a good thing to do. So we really rely on expert opinion, and the British Thoracic Society recommend that in an appropriate candidate who has first isolation of Pseudomonas with a clinical evidence of clinical deterioration, they recommend this type of strategy using IV ceftazidime and tobramycin for 2 weeks, followed by inhaled tobramycin for 3 months. That's actually the regimen that was used for that randomised study from 2015. The ERS on the right-hand side, you can see a flow diagram, and that's the sort of pathways that are recommended if you want to consider eradication. So it seems like a good idea. It doesn't have the evidence base to support it. You can also use an oral fluoroquinolone as your initial intensive strategy leading into inhaled therapy. So it's a bit of a work in progress getting the evidence to support that. Exacerbations, and I'm really pleased I didn't use the term tune-up to describe this, but there's acute exacerbations that are well defined, and we do see these sort of subacute exacerbations. These are patients who just have a general decline. They consistently culture Pseudomonas from sputum. They don't respond to oral antimicrobial therapy in the community. So they're not crashingly unwell, but they just have a general decline. And they do benefit sometimes from coming in and having intravenous therapy or more intensive antimicrobial therapy in conjunction with more intensive physio and other ancillary strategies as well. So the evidence base is also limited for exacerbations, and a lot of this, the data for this is also extrapolated from the CF data in terms of modes of therapy, antimicrobial therapy choices and durations of therapy. There's really no clear evidence to support dual versus single agent antimicrobial therapy in the non-CF mycoectosis population or an optimal duration. And so we again rely on consensus guidelines, and the BTS recommend, and I mentioned the BTS because their guidelines were published just a couple of years ago, prompt initiation of antimicrobial therapy, sputum bacteriology, modify antimicrobials based on sensitivity results. That all makes a lot of sense. The problem with that is, as Claire alluded to, sometimes the correlation between patient response and in vitro sensitivity testing don't necessarily marry up, but that's generally the recommendation. This slide really is from the BTS guidelines, and I just draw your attention to the duration, which no matter which organism you're treating, what agents you're using, the recommendation is 14 days. Now, that's a recommendation. Obviously, we can use that as a guide, but it will very much depend on how quickly your patient responds, whether they're not responding adequately at 14 days, whether you need to give them longer or less. It is a bit something that we tend to really rely on clinical response to determine duration of therapy. That's what the guidelines say, but it's not really based on any good hard and fast evidence. Other pathogens, Staph aureus, Streptomoniae are important. The non-tuberculous mycobacterial organisms, the slow-growing organisms or Mycobacterium avium complex, the rapid growers, Mycobacterium abscessus that Claire mentioned. Similar problem in the adult population, similar agents that we use, predominantly parenteral agents are the backbone of these regimens, and we really base that on drug susceptibility testing, but tolerance is also an issue in the adult population. So I just want to change track now for the final part of this, is really to talk about home IV therapies in Metro South. Just to orientate those who don't know about the geography in Brisbane, there's a north side and a south side. I work on the south side, and the hospital and health and service district I work in is called Metro South. So we service a big part of Brisbane south of the river, and our base is the Princess Alexandra Hospital, which is a hospital that I work at. So our home IV service was set up in 1988 as the alternate site infusion service, or ACES, but that morphed into this multi-dimensional service, which is now called the Metro South Acute Care at Home service, and it's an amalgamation of several community services. There's a standard HITH or hospital in the home, and in our hospital that really has a virtual ward, very similar to what Ben was describing earlier, but a little bit more limited in its scope. So really dealing with perioperative warfarin, cellulitis, pyelonephritis, heart failure, a full gamut of medical issues, but IV antibiotics are often part of that. The post-acute care service, really dealing with post-operative care, wound care, and short-term antimicrobials, and then the long-term antimicrobial service, which is morphed from the ACES. So the hubs are at the PA hospitals, some other hospitals in the Metro South region, but ACES, or the long-term antimicrobial service, operates centrally from the PA hospital. So this is just highlighting the difference between the long-term antimicrobial service and the hospital in the home service. So pretty self-explanatory that the ACES is for long-term IV antimicrobials, courses greater than 7 days. Generally, HITH is for short-term, less than 7 days. The ACES is overseen by the ID unit, infectious diseases, with weekly ID clinic reviews. The HITH service is medically managed by HITH SMOs, and they generally are general physicians. Patient care, in ACES, patient care is educated to administer their antibiotics. So this is about autonomous management of their own antibiotics, where they learn to self-administer their infusions. In HITH, it's all administered by nurses who go out and administer it in the community. In the ACES, once patients are competent at self-administration, then once weekly nursing review at the ID clinic is how it's done, and they always have a 24-hour phone contact. And in HITH, it's a daily nursing service. I won't spend a lot of time on this slide, but this is just a map outlining the geography of where the Princess Alexandra Hospital is located. Our catchment in this sort of blue area, but in fact, the catchment extends beyond the official Metro South catchment. Often we do have patients who come from other hospital and health districts. So really we need, to be involved in this service, we need patients who are willing to commit to complying with treatment. They need to be medically stable. All of them need to have central IV access, which is relatively obvious, but we use peripherally inserted central catheters in most patients. They need to have a safe home environment. They need to be able to attend regular clinic reviews. And they need to have a fridge to store the antibiotics. This next slide, look, I won't labour the point on this one, but really this just outlines the referral process. This is driven by our infectious diseases service. I'm a respiratory physician, but I collaborate with our infectious diseases services in these referrals. And basically, if someone's considered suitable, they're educated by the nurses, the pharmacists are involved in the choice of device and therapy. Then they're educated at home with the nurses who visit, and once they make sure that they're up and running and they're competent, the nurses just see them when required, and they have weekly ID clinic follow-up. The pharmacy team, we have 3 pharmacists and a few pharmacy assistants, and they compound these antibiotics on site for the following day. And the antimicrobials used in this service are most antibiotics that you can see listed on the diagram on that slide there: penicillins, cephalosporins, carbapenems, glycopeptides, etc. This next slide really looks at the types of infusion devices. So really, these are based around whether we use drugs that require intermittent infusions versus continuous infusions. And so these are the typical devices that are used, and listed on the left-hand side of the drugs where these are typically used. So we use spring-fused syringes, which are relatively inexpensive for intermittent bolus dosing. They tend to require some physical strength to use them. The elastomeric devices are more expensive, but they're more amenable to changing doses and flow rates, but they're more expensive. The continuous infusion devices, a couple of options that we have: the ambient pumps, and we can also use elastomeric infusers. So the patients are educated how to set these up with their antimicrobials and infuse the devices themselves, infuse the antibiotics themselves. Which antibiotics do we use for bronchiectasis? Well, piperacillin tazobactam is a common one. This has greater exposure. It's used as a continuous infusion compared to intermittent exposure. And we pretty much know how much and what rates we should infuse this over a 24-hour infusion to get an equivalent dose to an inpatient intermittent dosing regimen. And there's various things, situations where we might use higher doses, and pseudomonal infections are one of those. Other agents We also use ceftazidime. There's some issues with ceftazidime being used in continuous infusion, and I'm going to defer to Dr. Burke to explain some of the intricacies of that. Similarly, meropenem is unstable, and there are various combined stability and PK/PD models that guide dosing and continuous infusion models with that. But these drugs or these agents are used for bronchiectasis exacerbations, so in the home setting. The ACES service in respiratory disease, well, generally this service services 20 to up to 50 patients a week. That's in general. They're not all respiratory patients. They all need to fulfil the patient education self-administration model. And respiratory disease, we would have about one a week, most often bronchiectasis, other suppurative lung diseases, and our non-tuberculous mycobacterial infections also. I haven't mentioned multidrug resistant tuberculosis. That's another lung infection where we commonly involve ACEs, although it's becoming less common as we move more towards oral regimens for treating multidrug resistant TB. COPD and HITH, as I mentioned at the beginning, it's got a limited role mainly in short-term acute infections. Maybe the hospital in the home has a great capacity in COPD management, but we tend to have community chronic disease services that go into the community with nursing, physiotherapy and other allied health services who manage our COPD patients, largely with hospital avoidance strategies. But this is an area where perhaps in the future, better management strategies, particularly in the setting of the current environment, maybe looking at how HITH could be used to avoid patients coming in and having hospital care with COPD, which is such a common cause of reasons for patients coming to hospital. So in summary, control of infection is crucial in bronchiectasis management for the reasons I've mentioned. Prolonged courses of parenteral antimicrobial therapies are often a great utility in chronic suppurative lung disease, and we talked about bronchiectasis today. Less of a role in COPD, at least the way it's done in our jurisdiction. The predominant role of outpatient parenteral antibiotic therapy or antimicrobial therapy is management of exacerbations. I think that's where the main role is. There's other applications and other pathogens, particularly non-tuberculous mycobacterial infection. Evolving role in non-CF bronchiectasis eradication therapy, and I think we need a better evidence base to support that, but in select patients, I think that's a reasonable thing to do. Evidence base for efficacy and optimal regimen is limited. It's purpose-built, however, for outpatient parenteral antimicrobial therapy in combination with other adjunctive therapies, and this is an optimal management, or it's given as an optimal management with multidisciplinary approach. So the treating clinicians, the ID clinicians, nursing staff, pharmacy, and allied health. So it's a really nice approach to the multidisciplinary care of these patients. And on that, I will conclude. Thanks very much.
Great, thanks very much, Jeffrey. So next we have up Dr. Andrew Burke, who will be known to many of you. Andrew is an infectious diseases physician and a thoracic physician based at the Prince Charles Hospital here in Brisbane, and he's going to talk about pharmacology and the relevance of that for hospital in the home.
Thanks, Jason. Thanks for the invitation, and it's great to share this platform with the other speakers, all of whom have taught me much over the years, and the friends and colleagues. So it was a great introduction from Claire and Geoff, which sort of lays the groundwork for what I'm going to talk about. So I should say at the outset, I didn't have an acknowledgement slide at the end, but as an ID physician and a spiritual physician, I've learned a huge amount from the pharmacists in my departments. And since I was a registrar at PA, and even the Royal Brisbane 14 years ago when ID pharmacy was really coming into its own with HIV, and it's really evolved. So Sean Unman certainly helped me with some of the preparation of the slides, and I acknowledge Michael Williams and Matt Rawlings in Perth, and also Stephanie Rozzo, and I'm sure many others as well. So I'm going to talk a little bit about anti-pseudomonals, and I'm also going to talk about mycobacterial infections. We've actually switched around the order of these topics. And so Claire's already spoken about Mycobacterium abscessus, and I guess even though it's a rare disease in some ways, we see a lot of it. It takes up a disproportionate amount of time in hospital home and in their own practice. And the great thing is hospital home has really, for me, changed the way we manage these patients quite extensively. Even in the last 12 months, I think we've become much more efficient at utilising hospital home resources. So this is a 6-year-old mechanic. I've known him for about 5 or 6 years, and he had this really significant progressive cavity, which evolved quite subtly, really, over about a 12-month period. He was in another hospital, had a very minor amount of hemoptysis. A CT was fairly unimpressive, a little bit of nodular change, and then they did a repeat CT for some reason 9 months later, and then this catastrophic cavity had emerged, really without any significant symptoms to warn somebody of that. And he's been treated with many agents over the last 5 years, but some of the ones we've used for him have been amikacin, and tigecycline and imipenem. And these all have their own pharmacological challenges. And fortunately now we've found ways of giving all 3 of these drugs on hospital in the home. And I've had 3 or 4 patients in the last 6 months who have successfully completed most of their IV treatment on hospital in the home. So I'm going to talk a little bit about some generic aspects about pharmacology. So when I think about pharmacology, it's really about how drugs work, which is sort of the pharmacodynamics. How does a drug work on the pathogen? Or if it's a non-infectious disease, like how does a hypertensive tablet work on the vascular endothelium? For us, we're thinking about the pharmacodynamics on the pathogen. And then we look at the pharmacokinetics, is how the body metabolises the drug, or how does it absorption, distribution, elimination, metabolism, what does the body do to the drug? And we try to match those. So I know I was asking Jason, who was online tonight, and what sort of cohort we have, and it's very much a broad church of doctors and nurses and pharmacists and perhaps some other people as well. So that's great. So some of this will be familiar to some of you, some will be new, but hopefully there'll be something for everybody by the end. So something that we use a lot is the minimum inhibitory concentration, or MIC. And this is an agar plate here, and this is a strip of meropenem, or what we call an E-test. And down the very bottom of the strip, you can see 0.002. I've left my glasses in my car, but I think that's what it says. And you get a larger and larger number as you go high up to 32, which is roughly 32 millimoles per litre. And so you can see here where you get this teardrop effect, and where the killing zone sort of starts, we call that the MIC. Okay, so in this case, we'd say it's 0.06. The definition is using the unaided eye. So me with forgetting my glasses tonight, I might see a different reading if I had my glasses on. So there's that human element, a little bit of error there, and that could actually be significant because this is really a model, and that could exaggerate things one way or the other. That is probably relevant in some cases. And we can also do liquid broth approach, which again we have more concentrated drugs here on the left down to less concentrated, and the least amount of drug required to kill that bacteria or stop it growing is what we call the minimum inhibitory concentration. So that becomes a key pharmacodynamic or PD parameter that we use. There's a number of different, so those, you might recall those pictures Claire showed of the CF lung with the terrible bronchiectasis and some of the CT scans Geoff showed. And so if we go back to this sort of picture, we say, well, that's great. This is how the antibiotic works on a Petri dish. Well, how does it work in that catastrophically diseased CF lung? Or even that 4-month-old who had all that terrible secretions in the lower airways. So people have tried different models to try and simulate what we see maybe more in a clinical situation. And so hollow fibre modelling is something which has been used in a research capacity. And I suppose the way I see it, it's a bit of a hypothesis generator and a way of trying to come up with combinations of drugs that may work in complicated situations, such as, for example, bronchiectatic lung, or in situations of multidrug resistance, where we're trying to mimic what might happen in the body as opposed to what's just happening on a Petri dish. So it's a little bit complicated, but I think that the easiest way to look at it is think of it like a dialysis filter, okay? And you have this filter with thousands and thousands of fibres, and we call this a bioreactor. When you think of a bioreactor, I think it's something big, but this is actually a bioreactor. It's something relatively small. And you can, if this is the same model in cross-section, you can see within these fibres, we are putting the drug in and we're taking the waste out. And around all those fibres is like a soup of bacteria. And there's little ports here which you can access these bacteria. So you can watch how these bacteria change their behaviour, or whether they live or die or prosper or get antimicrobial resistance based on the combinations of drugs that you're putting in. So you can change the pH, you can change the concentrations of drugs, you can watch them with time, as opposed to just seeing something at a single time point. And we know that if we change the pH of a culture medium, it really changes the susceptibility very quickly. So we think about a bronchiectatic lung, often this is a very low pH environment, we think about lung cavities as well. And so drugs which may seem fine in a fairly normal pH environment can be really fail to do anything at all in a low pH environment. These things can be modelled in this sort of a situation. This is another way of just making things a little bit more complicated as well. And this is a nice study looking at Mycobacterium abscessus again. And I'm talking a bit about amikacin here, but this is on a solid media. And this is patients who, or isolates I should say, which were exposed to amikacin. So again, this is the same thing, this E-test, a very high dose of amikacin here, 256 millimoles, very low dose, 0.015. And what they've called here is the MIC, that solid white line, saying, well, we didn't see anything growing here. And you can see outside this red dotted line, there's a certain, what we call a morphology type or colony type. But in this sub-MIC zone, you can sort of see how they look a bit different, don't they? They don't have that sharp edge. And if you can see here, when it's exaggerated, you can see some of the morphology or the way these are growing is quite different. And when they looked at it under the microscopy, they could see in this sub-MIC zone, so they exposed to sublethal doses of amikacin, still enough to grow, but not enough to grow well. They found that there was a virulence factor was being selected out. So they would get this cording, okay, in the presence of amikacin. You know, in tuberculosis, when TB cords, it's a virulence factor. And under electron microscopy, they could see this rough morphology, which is again associated with virulence. So this is interesting that the way these antibiotics work, it's not an on or off switch, and that exposing people to antibiotics, we know generates resistance, but may also cause some quite profound behavioural changes in bacteria. And this is a standard PK-PD type curve that you often see. And this is just a note that we give a drug, it could be orally or intravenously, and intravenously obviously you have an immediately high plasma concentration. For oral agents, they have to slowly get absorbed or quickly get absorbed. And so we talk about if this is the plasma concentration of a drug, we have the peak concentration, or the Cmax, and then we have the area under the curve, which is all the shaded area. And so for different types of antibiotics, we're aiming for different PK-PD indices. So say for aminoglycosides such as amikacin or tobramycin for Pseudomonas, we're interested in the Cmax MIC. So that's why we can give a single dose of aminoglycoside can work over many hours, and that's because it has a post-antibiotic effect. So it destroys the ribosome. So even though it's cleared out of the plasma, the bacteria is still dying despite the antibiotic no longer being detected. So we call that a post-antibiotic effect. And the thing which determines the efficacy of amikacin is really that peak. We want that peak to be as high as possible without causing toxicity, so renal kidney injury or deafness, ototoxicity or vestibular toxicity. For beta-lactams, which is things we use in Piptaz, penicillin, ceftriaxone, meropenem, we're interested in the time above the MIC. So we really that's why we need to give these things 3 times a day or 4 times a day, because we really want an extended time above the MIC. Other drugs such as vancomycin, quinolones, often there's an area under the curve over MIC is often postulated. So those become quite important in how we look at things. So if we come back to the amikacin then, and I'm going to spend a minute or two on this slide because it's often hard to sort of take it all in quickly. But one thing I like, one little metric I use is the probability of target attainment. So this is in amikacin and Mycobacterium abscessus. So Claire and Geoff spoke about this in detail. So Mycobacterium abscessus, like the patient I showed you, the mechanic with that cavity, is highly resistant, and this guy hasn't been cured despite 5 years of attempts. This dotted line here is the distribution of MICs in abscessus. So the median MIC distribution for abscessus is about 16. So we'd sort of say above 64 maybe would be resistant, but even then 16 is quite a challenging sort of number to get to. And if we look at this dotted line here is 90%, so we want a Cmax over MIC, so a peak level of amikacin in the blood of a ratio of 10, okay? So you might want, the MIC 16, you're really saying you want a level of 160 in the blood, which is very, very high. And what we want to say is, well, is there a 90% chance I can hit that high level? And you see here that unless you have an MIC, relatively low, you're not really going to get those levels of standard dosing. It's not until you get 2 grams that for the average abscessus case, would you have a 90% likelihood of getting the target concentration that you want. So it's a little bit laborious, but it's just a way of trying to match this minimum inhibitory concentration to what we can actually achieve in the plasma. Now, we speak a lot about plasma. We do drug levels, TDMs, always on plasma, but then what's actually happening in the lung? And so there's always this suspicion that the concentrations we're getting in the blood aren't necessarily reflective of what's happening in a bronchiectatic lung or a lung with cystic fibrosis. So that's where some of those hollow fibre models can try and look into that. So amikase and TDM has changed a little bit in the last year or two. So I think traditionally we've done trough levels as a way of sort of covering ourselves. We like to have a low trough level. One of the I suppose it's a way of sort of covering your backside approach. We're trying to avoid being accused of causing renal injury or ototoxicity. So people always try to have an undetectable, very low trough level, but really we should be looking at the Cmax for reasons that I've said. And so now a number of centres now are trying to move towards just doing a trough level, but also doing a Cmax. And there's different definitions for that, unfortunately, but one would say 30 minutes after the end of the infusion. Some people say 15 minutes, some people say an hour. But looking at that and using that as a way of guiding treatment. And I would say since we've been doing that, we've actually been increasing our doses in about a third to a half of time. So I think certainly as adult physicians, respiratory physicians, we've probably been underdosing aminoglycosides in lung disease. So there's a number of dosing softwares now, which I won't go into, to help you with that. And area under the curve has been cited as a useful metric as well, maybe a bit more predictable than Cmax on its own. And there's a number of different, if you just Google area under the curve in Excel, you can find very simple ways of calculating that. And then you've got more complicated methods which use Bayesian dosing predictions. So often these are some of them are quite expensive, but the good news is for amikase, and there's free software available. So I'm going to move on to bronchiectasis now. This is a lady I've got in at the moment. She has a fairly resistant Pseudomonas, you can see here. So sensitive to colistin, tormentin we don't use anymore, really resistant to all the main drugs. She still does seem to respond to ceftazidime when we give it to her in 6 grams over 24 hours. But she's 70 now, and she's really getting less and less benefit with each of these courses of antibiotics. So what antibiotics can be given by hospital in the home? So there's a number of different resources. As a ID physician, I tend to go to the antibiotic guidelines, and the most recent guidelines have this chapter on community-based parenteral antimicrobial therapy, and Matt Rawlings was from Perth, one of the pharmacists there, was one of the major writers of this, and I know Jason, who also had input, and others. So I found this to be a very good resource, and it tries to synthesise some of what I'll say into something that we have readily accessible. And I guess the good thing is that many doctors now use this resource, probably hopefully everybody, but many people aren't aware that this chapter exists. And I was on the therapeutic guidelines. We had about an hour deciding what to call this chapter, and that's not an exaggeration, whether to call it HITH or OPAT or CowPat, and all things go on. The actual antibiotic choice was the easy bit. There's also this guidance from the NHS, which I think has been pointed, pharmacists have used and pointed me to it. It's about a 5 or 6 page document. It's actually quite a good resource if you're a physician who's not a pharmacist and you want to just get an idea of what are some of the issues in 15 minutes. I think this is a really good resource. So I'm going to talk a little bit about the stability of antibiotics for HITH, which is really important. And ID physicians are very good at trying to expect pharmacists to do miracles in terms of coming up with clever ways of making these things happen. But there are a number of limiting factors, but there are also ways of getting around that or adjusting for that. So one thing is that the common antibiotics that we use now have generally been well tested in hospital and the home, and we have a pretty good stability data. So, in the hospital ward, we take for granted what happens. The nurses make it up and they give it straight away. But obviously in the hospital and home situation, that's not always going to be the case. Sometimes patients, very health literate patients, I'm thinking here of adult CF patients or maybe paediatric patients whose parents are very health literate and competent, can often make these up themselves. And likewise, our NTM patients can as well. So it's important that stability trials have been done on these antibiotics. So they look at the storage period in the refrigerator, as well as in the infusion time. Some drugs can be given over 1 hour, like amikase, and others are going to be given over 24 hours. What's the stability like at the end of the infusion? Also, when patients have it next to their body, so we sort of say it's around 32 degrees. If they're sleeping with under their doona, then the tropics, those temperatures are going to be higher than when we in the compounding pharmacy in the hospital. So there's a number of different studies, which I won't go into, but a number of different methods that need to be done for us to be confident we can give this in the community. So looking at degradation products, looking at particle counts, pH, and there's a fairly good pro forma that can be used. The British Pharmacopoeia say that you should have a loss of less than 5% of the active compound at the end of the shelf life. And that's something which seems to be a KPI that seems to be used fairly standardly across the board. Other people say 10%. I think sometimes we discuss this in ID, and part of it, I think, depends on what sort of infection you're treating. So maybe wrong to say this, but sometimes for, say, pseudomonal bronchiectasis in an adult patient, we might say, look, if they lose a bit of activity in the last hour of the infusion over 24 hours, doesn't matter. But if we're talking about endocarditis, we might be really obsessive compulsive about that. So sometimes there might be drugs like ceftazidime that we may feel reluctant using in a gram-negative endovascular infection that we may feel more comfortable using in a bronchiectasis patient. Now, maybe we're wrong to say that, but it's just a bit of a give and take on what we think we can get away with. So these are some of the key variables impacting stability. So time, temperature, drug concentration, acid-base balance. So time is never your friend when it comes to drug stability. So time always degrades an antibiotic. And so this is looking at meropenem, and Geoff already commented that meropenem is objectively stable. And this is comparing it to doripenem. So doripenem had a bit of was the drug of the day 5 years ago and isn't used anymore. But meropenem, you can see here, looking at time over 24 hours, this is at 25 degrees. So you can see the degradation time is slower. And at 37 degrees, it's much faster for meropenem. But even so, even at the cooler temperature, maybe what we might say room temperature, it's still below that 90% threshold over 24 hours. We'd say that meropenem wouldn't be an appropriate drug to give over a 24-hour infusion. So there's different, as I said, there's different important standards that we use. We measure the fridge temperature standard, the body temperature, and the ambient temperature can depend on what climate you are. And certainly colleagues in Townsville and Darwin have done studies looking at how these formulations go in the tropics and how much they vary between more temperate climates. There's also ways of doing forced degradation studies where they deliberately alter the pH and see which way it goes, whether the pH is going, it goes up or down. And also looking at different time analyses. These are some of the studies done just looking at extended duration infusions, and I think this was Piptaz. I'm sorry, I've cut that off. But just looking at these are all different. All these lines are different patients. I'm looking at the time over 24 hours and the temperature, and some variation there depending on what antibiotic you're using and what temperature. So in terms of exposure to heat, so there's some trade-offs you can do. So if you know that something's going to degrade over time or over certain temperatures, then one option is to give shorter infusions and the other is to give multiple infusions. So instead of giving one infusion over 24 hours, we can divide it up, say for meropenem, maybe 2 infusions over 12 hours. And obviously that then creates implications for hospital and home services. Are the HITH services able to do twice daily visits? Some can, some can't. Many cases we get teach the patient to give a dose, so the HITH can come give one dose, see how they're going, check their PIC line for infection, and then the patient can give the second dose themselves or the family members. Obviously, that for some patients that's never going to be practical. We can give cold packs to keep something cooler. And one thing I think I saw was that for every 10 degrees, I'm trying to think of the number now, maybe for any 10-degree increase in temperature is about a 50% degradation. That may not be exactly correct. But there's a formula that pharmacists use that can be applied to try and predict the level of degradation. So something which I didn't know is that the higher the concentration, the more rapid the degradation. So again, if we know that, maybe we can do something by diluting it into a larger volume, which then may have its own issues with more prolonged infusion time. But nevertheless, there are things which can be done as well. So some drugs such as, so the other thing was now acid-base balance. So the degradation rate may not be constant across a pH range. And so the pharmacists can use buffering agents in the compounding pharmacy, so citrate and phosphate. And some drugs such as benpen, fluclox and piperacillin, their stability can be prolonged with the use of buffer agents. Meropenem, however, really can't be salvaged with buffer agents. So I'm going to talk about ceftazidime, and Geoff mentioned there's been a few issues with this. So the main problem with ceftazidime at the moment is this pyridine toxicity issue. And so this came out a few years ago when Baxter, I know there's a number of different providers, but I think Baxter and there's also Slater, 2 of the ones we use, but I'm sure other jurisdictions use other groups. So they felt that they couldn't provide ceftazidime in Baxter's over 24 hours. And part of this came because of changing guidelines for the concentration of pyridine. So pyridine is a natural degradation product of ceftazidime. It's known to be carcinogenic in animals. In humans, in very large doses, it can cause nausea and headache. But it's really, we've never found a case report of that happening as a result of ceftazidime being used in therapeutic doses. Nevertheless, the US Pharmacopoeia changed their guidelines a number of years ago. So they had said you could have 1.1 milligram per mil, and then they set an absolute daily dose of 2 milligrams, which meant that many of the ceftazidime doses would not meet that criteria. And the European Medical Agency had their toxicity guidelines, and then the British guidelines are very different. So rather than have an absolute number, such as 2 milligrams per day, they said 0.5% weight per volume, which was sort of interesting because it meant if you use a much larger volume of ceftazidime over a litre, then you could give huge doses of pyridine and still be within safe levels. So a lot of variability there. Suffice to say that ceftazidime has been harder to give over, partially for that reason. We can give it in Queensland Health, but we have to sign a waiver with the company to say that they're not going to be held legally responsible. Some providers aren't prepared to make it up. Some have with a waiver. So we're giving it twice daily over infusion. So it can still be used, and we haven't noticed any problems to date. And I've mentioned that just before. So the pragmatic approach to this, so we can split the infusions. Again, this is actually looking at cystic fibrosis patients actually, so how to minimise exposure to pyridine. And again, you can see here, the main point here is the temperature difference. So the higher the temperature, the quicker the degradation into pyridine. So giving cold packs and splitting the infusions over 12 hours may be a way of staying within that safe threshold. So this is just to say what is in the therapeutic guidelines. So just for the next few slides, I'll just cut and paste from TG. So it's got to be stable at 25 degrees or 8 hours at 37 degrees. So there's a number of different variations you can use, and I know that there's some difference between centres. So meropenem, as I said, degrades quite quickly. So that has to be given in split infusions, and it's not amenable to buffering, as I said before. So this is from the AIDH, and this gives some advice on how to give meropenem. And they've said some buffered solutions are stable for up to 6 hours at 32 degrees. So we do give it, but it does require extra HITH visits or patients giving it themselves. Again, this is just obviously straight from the ETG, but just really to point you to this resource about what some suggestions have been. I won't go into cefepime, same story, not stable over 24 hours, but can be given over 12 hours. So my last slide is just talk about therapeutic drug monitoring. I didn't really have time to go into that too much. We tend not to do that for respiratory infections to date, for say ceftazidime and so forth, but that might be something we need to think about in the future, particularly if we're giving, splitting doses over 12 hours and maybe trying to sail close to the wind with some of the PK/PD. Certainly we do that in say complicated endocarditis now at Prince Charles. We're routinely doing, when people on 24-hour infusions, we're routinely doing beta-lactam TDM. And if you want to see what sort of TDM assays are available, if you go to the Australian Society for Antimicrobials, go to this useful links. There's a list of all the drugs, and if you click on, say, for linezolid, Queensland Pathology can do that, as can St Vincent's, and we've developed this really for our mycobacterial patients. So we now can offer a lot of mycobacterial TDM, but certainly beta-lactams as well. So that was a very quick journey through the land of PK/PD. So I'm happy to take questions at the end.
Brilliant. Thanks so much, Andrew. That was fantastic. Now I'm going to invite Amy Legg, who's up in Darwin. There she is. Her face is on the screen that I can see so far, to share her video, and you can take over driving. Amy.
Hi, can you hear me?
Yes.
Great. Someone just needs to stop sharing their screen.
I think if you start sharing yours, I hope it'll work.
It's saying you cannot start screen share while the other participant is sharing.
Okay. I've got a wise young man who's approaching the stage to help us with this.
Down the bottom of your screen, does it say stop sharing? No. This is enjoyable, I'm sure, for the people at home. Got it. Hi everyone, thanks for bearing with us. Let me just put this up here. So my name's Amy. I'm a AMS pharmacist currently working up in the tropics in Darwin. And the title of my talk is The Patient Experience of Outpatient Treatments of Respiratory Infections, which hopefully will be a very interesting and insightful sort of tale that I've got to spin. So in terms of conflicts of interest, I've got none. I had a very funny joke about how I'll do anything for a trip to Brisbane, but then I wasn't able to go to Brisbane, so I had to take all those jokes out because I'm doing the talk anyway. So essentially what I wanted to do is maybe give you some experience of some of the things patients go through while they're on treatment. And then I started going through a single patient and I realized there was going to be enough to talk about for the whole 20 minutes just with one patient.
Amy,
Yeah?
I don't think you're sharing properly just yet that I can see anyway.
Good. Now? No?
No, one option would be to just quickly email it to me and I could put it up, but if it's not working,
sorry.
it should. Yeah. While we're organising this, feel free to go and refill that Chardonnay glass we didn't get a chance to earlier, everyone.
Can Amy try share again now?
Try sharing again now, Amy.
I'd love to.
That looks okay to me now. You just, yep, that's working on my screen.
Great.
Sourced as well for confirming.
Should be on the screen, however.
All right. Can everyone see that?
Yep, I think so.
Okay. All right. So this is patient FR, whose her treatment tale starts in 2017 when she was diagnosed with pulmonary MAC infection. At that time, she was 53 and she'd had Mycobacterium avium complex isolated in 3 sputum samples that was sensitive to clarithromycin. She weighed about 53 kilos and she was a horticulturist at Government House, which is an interesting career to have to end up with NTM. She presented with months of cough and weight loss, so she had some clinical symptoms there. And in 2017, she started her first treatment regimen, which was clarithromycin 500 milligrams 12 hourly, rifampicin 600 milligrams daily, and ethambutol 800 milligrams daily. And of course, as the pharmacist, you want to know a few more things. So in her history, it says other meds nil reg, which I think as a pharmacist, you really refuse to believe. I mean, what, she's never taken a Panadol? Give me any patient, I can get you a meds list of at least 3 meds, even when doctors say nil reg. But anyway, we don't know what other meds she was on. Probably nothing significant. She had a good renal function with a creatinine clearance of 99 mils a minute and a creatinine of around 50. She was a current smoker. She had a significant smoking history of about 45 plus pack years and was still smoking about 30 cigarettes a day. And she was quite engaged in care and, you know, keen to be adherent to her regimen. So I guess at this point, just to quickly go back to my pharmacist hat and sort of what the role of the pharmacist would be at this point. So I think it's really important to double check doses, particularly weight-based doses, and make sure that you're happy with the doses that the patient's getting. Always checking for drug interactions. So even with that simple regimen, the rifampicin is potentially inducing the metabolism of the clarithromycin. And to, of course, counsel on side effects. And I think these aren't drugs that we're used to using a lot, and it can sometimes feel a bit daunting to counsel patients when they start these sort of regimens, but it's really important that people understand what side effects they should be looking out for, and that can really help them feel more comfortable if they do notice things. So this is just a nice slide summarising the main side effects for the regimen she was on. She wasn't on aminoglycoside at this stage, but she was on the other three. So 4 months into therapy, she comes back to a ID, or if you're in Darwin, an IFD clinic appointment. Her weight has increased, so she's up to about 56 kilos. So also, as the pharmacist, make sure you're updating those milligram per kilogram doses as their weight increases. Her clinical symptoms had resolved, so she had no cough or sputum production. Initially, she'd been quite lethargic, but she had an improvement in that and was back at work. She was still smoking, but she did have some significant side effects. So she had visual symptoms, which she described as blurring of the vision at the periphery of both eyes while driving. And it turned out that she'd never had her baseline visual testing. So there was a lot of talk about whether or not we should be stopping her ethambutol at this point. And it's always good to remember E for ethambutol, E for eyes. That's always how to match your symptoms up there. And she had mild nausea with vomiting. So it was documented as mild nausea in the notes. She was requiring pantoprazole up to 4 times a day and metoclopramide. So I guess some of the other things to be counselling patients on to help them through these side effects is just the really basic things like the medications that you don't need to take on an empty stomach, people can take with food. And then what the best medications are to help deal with the symptomatic issues. So, clarithromycin's a prokinetic, perhaps ondansetron would be a smarter choice than metoclopramide. When I was researching this talk, I just found this little nugget in the BTS guidelines about proton pump inhibitors, which must be the most demonized class of medications ever. Everyone's trying to stop them, but every second patient's on them. Anyway, they had this nice statement that the impact of proton pump inhibitors is unclear, but PPIs have been reported to be associated with MAC pulmonary disease and may promote gastrointestinal survival of MTM and subsequent lung infection through gastric aspiration. Anyway, she was counselled to not use the pantoprazole as much as she was, and they did some, non-pharmacological management of her nausea. So 5 months in, she came back to clinic, and the doctor that saw her at this point picked up that an ECG hadn't been done and explained to her that she needed to have cardiac monitoring while she was on medications such as clarithromycin that can promote the QT. So nothing else was changed, and she was sent off to have a QT and come back in a month. At the next appointment, which is a little over 6 months into treatment, the patient had sort of not fully understood what the ECG was and was quite anxious after the discussion, and so stopped her clarithromycin. She had cough, she had new chest pain, and she had some other side effects, abdominal cramping, intermittent vomiting, and loose bowel motions. That was preventing her going to work, and she'd stopped all her medications. So I think it's really important to acknowledge how significant some of these side effects can be and what the impact is that they've had on this lady's life, who was quite engaged with care at the start, and now she stopped all her medications. I just wanted to take a little break of the case. There was this really interesting FDA report that came out in 2015, where they held a public meeting on NTM infections to try and gain an understanding of the experience of NTM patients and caregivers, and try and understand what the significant symptoms were, how they impacted daily life, and what the treatment experience of patients was. They had about 50 patients attend and 25 people respond online. And some of the learnings that they published from this are really useful. So I just want to share some with you now. So the key themes that came out of this are probably things that, particularly if you've been involved in treating patients with NTM infections, are quite repetitive, but that the infections cause debilitating symptoms, including fatigue, cough, and shortness of breath. One of the things I found interesting is the patients described the cough as relentless and time-consuming. I think that really can resonate. Trying to stop and cough for 10 minutes, it really does take up a lot of time. I found that I could really relate to why people would find that so debilitating. And just also how people experience this drastic change from their active and independent lives before diagnosis, and their decline in health caused them or their loved ones to limit or completely stop participating in activities that they once enjoyed or were able to do, which led to social isolation, which, I mean, sure, great during COVID, but not for the rest of the time. Participants also shared that their constant coughing was misunderstood by others as contagious, which left them or their loved ones feeling stigmatized and embarrassed. And I think that's another thing that has happened and been reported, particularly for some of the MDR TB patients trying to go back to work and coughing and having co-workers not wanting to sit in meeting rooms and not wanting to share staplers. And it would be really interesting to get some insights from any of the other people here about engaging with workplaces and whether there's more we could be doing to facilitate people going back to work and not feeling stigmatized by their coughing and symptoms and people not understanding what that is. So then in terms of the drugs, people obviously had a variety of drugs and they emphasized the downsides of treatments because of their life-threatening side effects, and that they valued the benefits of non-drug therapies, particularly exercise and pulmonary rehabilitation. So it's just another sort of point for us as clinicians in trying to promote the non-pharmacological things as well. Nearly all participants expressed the need for treatment that was effective and that they would like them to have minimal life-threatening side effects, which I really like. I mean, people aren't even asking for no life-threatening side effects. They're just asking for minimal life-threatening side effects. I just think, what a bunch of troopers. They really obviously wanted to see efficacy though, so they wanted to see a decrease in the number of exacerbations and ideally less complicated dosing schedules. So, I mean, I guess we can all understand how some of these treatment regimens can be quite difficult. In terms of the side effects that people experienced, before I get to that, one of the things I also found really fascinating was that people didn't often have clinical improvement. So they were only finding out if they were doing better when their doctors told them at appointments. So people have said, you know, they are only aware of improvements in their condition through lab tests and imaging results. So you can imagine the pressure that they have when they go into these appointments and they're really looking for their physician to tell them whether or not they're getting better. And then in terms of the side effects, it's the things that we would, you know, obviously be expecting: so neuropathy, numb toes, severe vertigo, hearing loss, eye changes, sensitivity, stimuli, nausea, reflux, you know, etc. And then in terms of the regimens, the majority of participants commented on the burdensome nature of prescription drug therapies. So some medications have to be taken with food, while others have to be taken on an empty stomach. And you know, that's feedback that we get from patients for a variety of infections, that can be quite difficult. And just that can be quite tedious. It can affect travel. It can obviously affect work. What I found really interesting was that participants really valued the non-drug therapies. So that included things like exercise, pulmonary rehabilitation, breathing and relaxation techniques. And that the second paragraph on this slide is really about the consistent messaging that participants really enjoyed exercise, noting it was a lifesaver and the key to staying well. One participant noticed that in addition to the drugs, exercise helped boost her energy, mental acuity and oxygen stats. And despite fatigue, shortness of breath and concerns, participants commented that they still wanted to push themselves to exercise because of its benefits. So I just, you know, wonder if that's something we could be promoting more with some of these patients. All right. So back to FR. So we're 6 months in. She stopped all her therapy a week ago. She's quite anxious about her tablets and what the side effects are. Here we go. So she stopped all her meds. She was seen in clinic with chest pain. And the next day she was admitted to the Royal Darwin with chest pain, troponin rise, and diagnosed with a non-STEMI. So she was started on the 5, you know, traditional non-STEMI drugs, very reluctantly, and sent home to go back to follow up with infectious diseases about her NTM treatment, remaining off all NTM treatment at that stage. Interestingly, her it may not have ended up being a non-STEMI, but we won't get into that. So she's still off all her medications at this point, and in September 2018 she comes back to the infectious diseases clinic. She's had another MAC isolated in July. So she restarts clarithromycin and ethambutol. She's quite convinced that the rifampicin was implicated in the non-STEMI. And she restarts the clarithromycin at 500 BD, and now she's not got that rifampicin on board that was potentially sort of chewing up the clarithromycin and decreasing exposure. Her weight's at its lowest at about 48 kilos, but she declines dietitian referral due to too many appointments. And another sort of, takeaway point there about trying to facilitate easy access to multiple clinics, booking things on the same day, appreciating how hard it can be for patients with lung diseases to walk from the car to the clinic, and particularly in, really big hospitals going between clinics. At this point, FR's already got cardiac appointments, infectious diseases appointments, and she's trying to work, and it would be really beneficial for people to be attending things like dietitian appointments. And so how can we facilitate that and make it as convenient? Can we book it in straight after the ID clinic? So about a year ago, she's been going great guns on clarithromycin and ethambutol, but it's decided to add a third drug. So she gets isoniazid and some B6. Then in May, so a couple of months later, she's tolerating the isoniazid well, and someone really goes through her medications and identifies a few miscommunication issues that have come up. So the isoniazid, she's painstakingly taking 3 times a day instead of 3 tablets once a day. The clarithromycin, at some point she'd misinterpreted that she was meant to be taking 2 twice a day instead of 1 twice a day, so she was just taking 250 BD. And her ethambutol, she'd run out 3 to 4 weeks ago and wanted a rest, so didn't call the TB clinic. So one of the things that the pharmacist at that time did, which I think is very good, was start a Webster pack. And she still raves about the Webster pack service, and she's really appreciative of that. And so shout out to the RDH HITH pharmacist, Linda, if you're on the line, doing a great job there. At the end of 2019, she's another sputum positive. Her vomiting's increased, and whether or not she could have been on a lower clarithromycin dose is sort of a point for another time. And her sputum production has worsened, and she's thought to be failing the current regimen. So this is, 2 years in at this point, and she's getting some more bad news, despite all the tinkering, that she's probably still failing. So at the start of 2020, we called the expert in Queensland, who was the presenter before me, and we changed the clarithromycin to azithromycin, so in an aim to increase GI tolerability. I guess there are the issues around azithromycin and cardiac events, but actually the BTS guidelines do note that that has never been reported in NTM, but I guess it's definitely still a consideration. We add clofazimine and add in IV amikacin and continue the ethambutol, but increase the dose as she's gained a bit of weight. So I just briefly thought I'd talk about TDM for mycobacterial infections, but Andrew has done a good job of that, so we won't spend too long on it. In terms of TDM, it's only routinely recommended for the aminoglycosides, although I think personally I'd like to see it, for all the drugs, but at least now we'll focus on the aminoglycosides. For amikacin, as Andrew said, we do peaks and troughs. Outside of NTM, so sometimes we've done AUCs for moxifloxacin for MDR-TB, and there might also be a role for AUCs for linezolid. It's really important to try and do those if you can, if the patient's an inpatient. It does take a lot of blood collections, and it can be quite annoying. So just my advice for that would be to make sure you try and do them while the patient's an inpatient. Also, just with doing TDM, always make sure your target and your result, the lab, are both unbound or both bound, just so you don't get yourself into any trouble. And as Andrew mentioned, consider concentration at the site of the infection. One of the things that does come up is whether or not we should be dosing 3 times a week or daily. And so there's obviously, clinical indications for doing daily regimens as opposed to intermittent regimens. So, regardless of that, this was just a nice study from 2003 by a group of infectious diseases and pharmacokineticists from Colorado. And so they were able to sort of show that for all the aminoglycosides, that dosing at 15 milligrams per kilogram daily or 25 milligrams per kilogram 3 times a week wasn't altering the likelihood of toxicity. And they did also find that there was subjective changes, or the subjective changes in balance and hearing may have been amenable to alteration of the rate of infusion of amikacin. So that's largely, we all do it over 60 minutes, and they certainly found that changing the rate of infusion from 30 minutes to 60 minutes really helped with those side effects. And just to point out, this wasn't a study looking at efficacy, but just looking at toxicity. And just one of the other things that Andrew sort of mentioned that I sometimes find a bit difficult is you don't often get really good targets for the NTM infections, but I think you know, often people just give the target for the daily regimen, but obviously if you're giving a bigger dose, you're going to get a bigger peak. And it was just, you know, it's just useful to see in this study that obviously if you're giving amikacin at a bigger dose, the peaks that they achieved were, you know, the average was 80 and the range was 54 to 98, whereas when it was administered daily, they were getting peaks of around 46. So back to FR, her amikacin is going well enough. Her troughs are undetectable. Her peaks, she is on a 3 times a week regimen, so her peaks are, you know, reflective of that. Her creatinine has gone up, so her creatinine was 50 at baseline and now 74 with the subsequent reduction in her creatinine clearance. She's had some high frequency hearing loss, but she doesn't find that significant on her day-to-day life. She's tolerating her other meds okay, but she feels very fatigued and is not working. Her main complaint was her feet feel like they've had cordial spilled on them, and she was interested to know if any of the drugs could cause that, which I'm still endeavouring to work out. And at the moment she's planned for surgery, which she's absolutely terrified of, and she's just desperate to stay on the drugs. She'll do anything to stay on the drugs, and she's very anxious about surgery. And I feel like she's just had so many ups and downs throughout this whole treatment course, and at one stage she just didn't want to be on the drugs, and now we've put surgery in front of her and she's just absolutely desperate to be on the drugs, and it just must be very traumatic for her. So to summarise all of that, hopefully there was some learning points throughout, but I think that a lot of these, or these 3 points have come from patients, and so they would really like a drug to kill the bacteria without killing the patient in the process, which is just fair enough. A desire for drugs that were faster and easier to administer and had more convenient dosing schedules. And they were really interested in more oral or inhaled medications rather than IV medications. And I think just really I wanted to say, you know, NTM treatment is a long and tedious path, and sometimes you can find it difficult, but if you're finding it difficult as the healthcare professional, I mean, you can only imagine how difficult it must be for the patients. And good therapeutic relationships are so important. Patients on multiple meds for a long time need thoughtful healthcare professionals. And particularly for the pharmacists, I think it's really important to get involved early. Think about supply, think about administration, think about non-drug options, therapeutic drug monitoring, and really just be supportive. That's it.
Fantastic. Thanks very much, Amy. That's wonderful. So now we would like to invite any comments or questions that any of the participants online may have. You can do that either by sending some messages through the chat function, or alternative, which would be easiest, or if you'd like to talk verbally, then that would be okay as well. We have a question from, it might be Michelle Rice, I'm not sure, but question is ertapenem a suitable alternative to meropenem in hospital and the home? And I can see Andrew smiling there, thinking about as long as it's not a Pseudomonas infection, it has great stability.
Yeah, great, thank you. So yes, we use it quite a bit, as Jason just answered the question. So ertapenem doesn't have activity against Pseudomonas, which sometimes is a good thing because you don't want to select out for a carbapenem-resistant Pseudomonas if you're not targeting that in a disease state. So it's obviously once a day, which is very attractive. So We certainly do use it in, not so much in respiratory disease, I suppose, because we wouldn't use it for Pseudomonas, but more so in gram-negative infections.
Andrew, I'll just make the point there that you always need to check the susceptibility to ertapenem independent of meropenem, because there's sometimes a difference in susceptibility for Enterobacteriaceae especially.
Thanks, Ben. Are there any other comments which people may want to make? I may have a question for Amy whilst we're waiting. Amy, I wanted to ask about if you have any perceptions from the patients that you have interacted with that have received therapeutic drug monitoring. They have to physically go into the hospital to have samples taken and wait for results to come back, before a dose is given, or the timing of their dosing in terms of it being 3 times weekly might drop to twice weekly or something, depending on how they're clearing, say, their amikacin. What their perception is of that. Does that sort of change their routine frustratingly for them, or do you have any comments on that?
Yeah, I mean, it's a really interesting question. The thing that I always find quite interesting is people are just fascinated by the results. And I think if you're going to take someone's blood for a drug level, you have to expect that they're going to want to know the results. And I hadn't really appreciated that. I had I guess I'd assumed that they wouldn't, understand it because I maybe barely understood it myself. But I think, if you're doing this, people will absolutely want to know information that relates to them. And my personal experience has been that if you explain to them, this drug has side effects and I just want to give you the dose that's going to be effective and not cause toxicity, and the best way I can do that is to know what exposure you're getting in your body as opposed to what the average person gets in their average body. People are really interested in that, and they want individualized care, and I think it's just really important to make sure you go back and explain to them what the result was and what the meaning was, and then I find them very, really interested.
Amy, it's Andrew Burke here. Look, you've worked in Brisbane for many years and now you're in Darwin. How do you find working in a regional rural area compared to, say, the Big Smoke? How have you found differences in what you can offer and so on?
Yeah, that's been really interesting, actually. So I didn't realise how spoiled I was actually in Brisbane in terms of therapeutic drug monitoring, and I'm pretty confident that the Royal Darwin Hospital has never seen so much therapeutic drug monitoring since I arrived, because it does make a big difference. Actually, up here we send off an amikacin level, and it often takes 5 days to come back, which it took me a long time to get used to that, and I'm sure there's people online who are shocked that I couldn't deal with that, but it does make a big difference. So the big thing I found has been the therapeutic drug monitoring, so not having easy access to beta-lactam and any sort of non-standard therapeutic drug monitoring. You notice that with patients because you have to, keep giving a dose that you might not feel 1,000,000% comfortable with. Interestingly enough, the heat issues haven't been as significant as I thought they would be in terms of stability, probably because people can largely either be in air conditioning or people are largely in air conditioning, to be honest. And so that hasn't been quite as significant as I thought it would be. But the difference in infections as well, so the need to use lots of ceftazidime for melioidosis and the implications of the breakdown products, that has been a huge issue. And so when you're doing large volumes, going from 24-hourly infusers to 12-hourly infusers, doubling your costs from $100 a day to $200 a day, for a small proportion of patients, that's probably not particularly unpalatable, but it's quite unpalatable when you look at the number of patients that we're doing it for up here. I don't know if I answered your question, but I feel like I've spoken for a significant period of time.
Thanks, Amy. The next question I'm going to direct to Ben, but it may also, you may have a comment on this, Amy, because your insights are so valuable to all of us. The question comes from Horst from New South Wales. He's saying that we have great variability with regards to meropenem in OPAT and HITH, the way that it's performed. And he wants to know if we can see a national rule whereby we will accept twice daily administration for some conditions and accept that 80% bioavailability is acceptable for the end of the infusion. Ben, I'm going to throw that to you first with your medical hat on and your role with your association with the hospital and the home society. See what your thoughts are.
Look, I think it's a really good point and a very interesting question that we often face where, you know, meropenem is the only suitable antimicrobial, and if we don't get the patient onto OPAT, they're stuck in hospital. You know, it's a tricky situation because I guess the stability and bioavailability goes against all the recommendations. So it would be a little bit hard to, you know, really have a rule or a regulation that went against them. And, you know, our approach is to really do it on a case-by-case basis and look to see if there is another alternative. And if there's not, use meropenem twice daily. We always actually, pharmacy asks us to consent the patient to make sure they're aware that we're using it in an unlabelled fashion. I think we get our infusers from Baxter, and in fact, we're using them well beyond the labelled stability. As a very practical thing, if we want to give a 3-gram dose or the equivalent of a 3-gram dose on a hospital in the home, we typically give 2 2-gram infusers each over 4 hours. Don't tell me if that's right or wrong, Jason, but it feels like it's about okay to me. So look, I think it's, you know, it really is because it is, you know, outside acceptable stability and kind of labelled indications. It really needs to be on a case-by-case basis. And it is expensive by the time you buy 2 infusers and send a nurse out there twice. So there are a few issues with it.
Amy, do you have a comment?
Yeah, I just want to say one of the things that I think that the ceftazidime and meropenem for me are very different. So the meropenem for mine, if you can do therapeutic drug monitoring at the end of the infusion, you still have an adequate level. I feel quite reassured by that because I don't think the degradation products are particularly worrisome. What have I got to base that on? Not very much, but anyway. Whereas the problem with the ceftazidime is even if you can do a drug level and prove that your ceftazidime is fine, which is, you know, has never been the problem, what you can't do is a drug level for the breakdown product. So I do find therapeutic drug monitoring can be really helpful in those meropenem situations, but obviously less so for ceftazidime.
Thanks. The next question is from Linda. This might be for Andrew. It relates to a patient who's receiving a 25 milligram per kilo dose of amikacin with undetectable trough levels but not achieving high enough peaks. Would you consider increasing the dose above 25 milligram per kilo?
Thank you. So I think we would. So then we're sort of moving towards not getting too, it depends how high. So we chicken out at a certain level. I couldn't give you an absolute number. So we do try to get a peak of around 60 to 80, but sometimes that doesn't reach that Cmax MIC target, which it could be 10 in the plasma or 20 at the site of infection, which is the alveolar fluid. So, you know, once we're getting above, sometimes if the MIC is high, I think the question really comes down to partially the MIC. So if the MIC is very low, we see that in say, drug-resistant tuberculosis, the MIC is around 1, okay, on average for MDR-TB, whereas for abscessus it's around 16, so much higher. And so for treating abscessus or NTM, you often need, in theory, much higher peaks and higher doses of amikacin than you might in drug-resistant TB. So it's really, often that's impossible to achieve. So we try to get around 60 to 80, okay, but we wouldn't really go for a peak above 80 because we'd feel uncomfortable with that. But there's no evidence for that really one way or the other. It's just more gut feeling.
Can I just extend a little bit more on that? The fact that the amikacin susceptibility testing is done with it as a single drug in the susceptibility testing method, but you're actually administering as part of a combination therapy approach, does that sort of reassure you that maybe you don't need to achieve those peaks which have been defined most frequently from PK/PD studies where it's used as monotherapy in systemic gram-negative infections as opposed to maybe in mycobacterial?
Yeah, so you might remember some of that hollow fibre modelling I spoke about tries to look at that, like how do these, we don't give these drugs in isolation, and so we give them often 3-4 at a time, and so maybe some are doing some heavy lifting and compensating for the slackers. It's often hard to untangle which is which. So it certainly is felt that having said that, in Mycobacterium avium complex or MAC, it is felt that a high MIC of greater than 32 or 64 is associated with failure. That was sort of a rough exclusion factor for one of the most recent studies. So in theory, I think we do get away with it. So sometimes I've had a patient just today I saw with abscessus who had very resistant looking biogram, resistant to tigecycline, resistant to we don't dig tigecycline, resistant to imipenem, amikacin, etc. And yet he feels a lot better on the combination regimen. So clinically, we do see people get better despite what the susceptibility says, and we see the same in Pseudomonas and CF, where that biogram often doesn't predict outcome, presumably for different reasons because there are lots of different quasi-species in there.
Thanks, Andrew. Next question is addressed to both Andrew and I. I'm happy to take this one, Andrew. It relates to transitioning a patient from intermittent to continuous infusion antibiotics, and when is the best time to start that continuous infusion? Should you use a loading dose? And is there a difference for beta-lactams and vancomycin? So my opinion is here. So I've studied a lot of continuous infusions in the context of critically ill patients, but obviously that includes understanding what happens in non-critically ill patients as well. I think that the loading dose is appropriate for two reasons. Firstly, to get a rapidly acceptable or therapeutic concentration such that you can start the bacterial killing to enable the antibiotic to work as quickly as possible has been shown to be very important in sepsis. In this scenario, whereby a patient may be relatively well on the wards, I think that there is a pharmacokinetic advantage to getting to higher levels faster with a loading dose. But the delay we're talking about with a continuous infusion is no more than, say, 1 to 2 hours. And so I think from a timing perspective, it isn't as important per se, if we think purely about blood concentrations. And but in terms of a quality of practice and what a best principle, it certainly is best principles to use a loading dose before going into a continuous infusion. In terms of the timing of when to commence that continuous infusion, it could be for vancomycin or a beta-lactam. Typically, about half the duration of a normal dosing interval would be the way to go, I think. So if it's meropenem with the usual 8-hourly dosing interval, if you were to give a loading dose of meropenem, say of 1 gram, then you might start the continuous infusion 4 hours later. For vancomycin, if you were to give a 1 gram loading dose or a 2 gram loading dose, then waiting 6 hours or so to give the continuous infusion to have that commence would be what I would be recommending there. So I might just see if there is any last questions, and otherwise draw this to a close. We're certainly happy to take any questions by email from those that have it, and otherwise I'd like you all to, just from a virtual perspective, join me in thanking the presenters, who I think gave some wonderful insights in terms of the challenging multi-drug resistant infections that can be encountered in some patients, and what that means for choices of drugs that may be used both in hospital, but then of course out of hospital as well from Claire, and the different indications which may be used in terms of COPD and bronchiectasis, which Geoffrey presented on, and the antimicrobial use in that context. The pharmacology that was presented by Andrew, and all those important considerations in around not only dose, but also those other factors which affect what dose you may use in terms of drug stability. And finally, for Amy for providing her account of exactly what some of these challenging infections can mean for the patient, and some of the perceptions that they have about what is being done. And in the context, I thought it was a very nice way for her to complete what her presentation was that that scenario which the patient was confronted with about surgery versus ongoing drug treatment. And it goes to show that, you know, they really do appreciate the high level of effort that's put into treating some of these infections. And if that means they can avoid surgery by having high quality care, then that's a fantastic result. So thank you again to all of the presenters. Thank you for those that joined us online to make this an interactive discussion towards the end. Thank you to the sponsors, MSD, Pfizer and Baxter, for allowing this to occur. And just to remind you that we have 3 more of these webinars that we're planning throughout the year. They're going to be in, well, at the moment they're planning to be in different cities around Australia, and COVID-19 willing, it would be nice for us to be able to do that and to take this roadshow around the country to give other cities the opportunity to participate, hopefully in person, with some of these discussions as we move through different therapeutic areas and applications for where OPAT can hopefully help improve the care for some of these patients that require very long courses of antimicrobials. So I'll conclude there, and thank you all very much for your presentation and participation.